This episode of CRST the podcast is sponsored by Nova Eye Medical.
Hi, I'm Rob Noecker here, and I'm here with Ahmad Aref in Chicago. We're at the Interventional Glaucoma Congress for 2021. And today we're going to talk a little bit about corneal health, endothelial cell health specifically, and how it relates to procedures that we do to control IOP. Ahmad, thanks for being here.
Thanks, Rob.
Okay, so what we're going to talk about first is endothelial cell loss. And what's your decision making when you go to lower intraocular pressure? Is this something you worry about?
Well, yes, I think in recent days, recent years, of course it's something that we worry about. With our conventional glaucoma filtering operations, it was an accepted part of the procedure, it was an accepted risk with trabeculectomy and aqueous shunts. But these days with, the burgeoning of so many MIGS, microinvasive glaucoma surgical options that of course provide efficacy and also have significantly increased our safety profile, we now can start to micromanage, if you will, the safety profile of our various MIGS procedures. And we know that although the safety profile has been elevated to a whole nother level, we know that these procedures are not entirely innocent to the corneal endothelium. We learned that with the CyPass device, which, after demonstrating really great efficacy, was a procedure that I did frequently, but after 5 years was shown to cause progressive corneal endothelial cell loss, and unfortunately was withdrawn from the market for that reason. And so, since that time and over the past few years with all the growing options, it's something that I consider anytime I make a surgical decision.
No, and for me, and I agree with everything you said, and for me, I think it speaks to one of the reasons we put off glaucoma surgery. The way I was trained in residency, you put off glaucoma surgery as long as you could because it was going to be bad in the long term.
Right.
You had to do it, and to get a short-term, IOP lowering, this it kind of saved the vision, but it was already going bad. Versus now, I often talk to patients about being proactive and doing like cataract surgery alone to, or cataract surgery combined with something like the iTrack, just to lower intraocular pressure and be proactive. Because I think with this procedure, and I think the study we're going to talk about, we did it in combination with cataract surgery. And my position is that the canal-based procedures work best in pseudophakic eyes. I always worry that the angle is not static, and if it's a phakic eye, if it's a big old high myope, maybe it's okay. But what do you think about that? What population do you use it in?
Well, I think in terms of our canaloplasty procedures, it's a very versatile procedure. And so if I were to think about the most frequent place that I use it, it's probably that patient with mild, moderate disease who is suffering from a cataract. I mean, that's an easy decision for me because I am not incrementally increasing the risk that the patient has already accepted from cataract surgery alone. And your study helped to solidify that. And then, beyond that, I can use it standalone procedure in patients who are pseudophakic or even phakic sometimes if we need that. And it can use it in patients who are suffering from secondary open-angle glaucomas, not just primary open-angle glaucomas, but all of the difficult and challenging types of glaucomas that I'm sure you see in your practice that are related to maybe retinal disease, retinal therapies, or even to corneal disease. I've done this procedure in patients that have had corneal transplants.
No, and I think you're right. And like I said, in some ways, this is not like a new concept at all. When you look back at trabeculectomy or tube shunts, it was kind of accepted. I mean, it's widely proven that big tube shunts in the anterior chamber sooner or later do in the cornea endothelium. So, and I think the question now is, with all these micro or minimally invasive techniques, are there micro or minimally invasive enough, to really change the curve of what's going to happen and not guarantee inevitable endothelial cell loss?
Right, I think that's absolutely right. I think we've enhanced the safety overall, there's no question, but we want to maximize that, the degree of safety that we're affording our patients. So I know that yourself and Dr. David Lubeck performed a very well-conducted prospective study looking at endothelial cell loss associated with one of our MIGS procedures. Can you tell me a little bit more about that?
Sure, and I think it's it's an ongoing study. We've pooled our data from a prospective trial looking at combining cataract surgery with ab internal canaloplasty. And once again, it's primarily, we know this is a good procedure for lowering intraocular pressure. It works as well or better than pretty much anything else we do. But the question is, how relatively traumatic is it to the cornea endothelium? And what we found was, actually, I was a little bit surprised, a remarkably low endothelial cell loss, around 3% or so. Not really much different than what we expect with modern cataract surgery alone. Certainly when you look at the data from older procedures, there's a much higher rate. So I think that's encouraging because, there's a number of steps in that procedure and it's a very thorough procedure. But I think my explanation of may that YB is a lot of it is out of the anterior chamber. We're targeting the canal, which is the problem organ in glaucoma, and we're not doing a lot of kind of excessive manipulation in there. We're not leaving anything behind either.
So Rob, 3%, and that was iTrack Canaloplasty combined with cataract surgery.
That's correct.
And how far out from the surgery was that 3%?
So the latest data we have is 12 months out. So once again, it's ongoing and we continue to report updated results at some of the future meetings here in 2022. But yeah, so 12 months out, and that's a good break point, I think. 6 months, I always say with glaucoma surgery, the first 6 months, everything looks pretty much great, right? I mean, we're always happy at 6 months. Yeah. I think the truth comes down later on down the line at 1 year, 2 years, and we saw that with the CyPass data that it wasn't the first year when the break started to happen. It did take some time.
Yeah, I mean, I think it's remarkable that yourself and Dr. Lubeck were able to get just a 3% reduction in endothelial cell loss for a procedure that was combined with cataract surgery. Historically, if you look at cataract surgery alone, you're probably looking at about a 10% loss. Mm-hmm. So 3% for you guys, I think that's fantastic.
Well, Dr. Lubeck's a great cataract surgeon as well, so that never.
No, you are as well. Very humble, Rob. No, the two of you, I think, speaks to your surgical skills in general, but also I think speaks to the gentle nature of the iTrack procedure. And it's a procedure that's performed, as you said, away from the corneal endothelium under the protection of viscoelastic. Mm-hmm. So very little incremental effect, if any, to cataract surgery alone.
Yeah. So let me ask you. So why do you think in terms of the mechanisms of action, in terms of what we're doing, when we choose MIGS, and that's kind of the way the thing is now, we have a lot of options, as you said earlier. How does the way we lower intraocular pressure matter, or how much we do it, or what do you think?
Right, I've been thinking about this a lot, as the number of options have grown, as I have my choices of procedures to be performing on my patients. I think very critically about each of these procedures and the safety margin of each of those procedures, particularly the safety margin as related to the cornea endothelium. So when I think about how corneal endothelial cell compromise occurs postoperatively in our patients, we think about it as occurring via 3 mechanisms typically. One is a mechanical mechanism. We know that from studies that look at our tube shunts. The closer that the tube is to the corneal endothelium, not surprisingly, the higher the risk is to damage the corneal physiology, corneal endothelial cell physiology. The second mechanism would be inflammation, intraocular inflammation, and changing the composition of the aqueous to be pro-inflammatory in nature. Inflammatory cytokines, we know, have negative effects on those intercellular endothelial cell junctions, cause the corneal endothelium to become more leaky in nature. And then those aqueous cytokines also decrease sodium-potassium pump density. So the corneal endothelium doesn't function as well at pumping fluid out from the corneal stroma. And then third would be this idea of segmental aqueous flow. Physiologically, aqueous flows across 360 degrees of the cornea in a 3-dimensional manner, bathes the cornea endothelium in a diffuse manner rather than being segmentally directed anywhere. Mm-hmm. And there's good evidence that segmental direction of aqueous can cause mechanical damage to the cornea endothelium and corneal compromise in that way. In terms of the various MIGS procedures that we have, I personally am looking for something that as closely as possible mimics natural physiologic outflow, ideally without the need for a device or anything artificial that can potentially cause any of those 3 mechanisms and subsequent corneal endothelial cell health decline.
Yeah. No, I think those are good points, and I think I would just add that you brought up the idea of devices, and once again, I had great success with the CyPass, and I was very sad that it was removed from our armamentarium. But it just shows you that it makes you question a little bit, is any device totally safe to leave in there? Just because the eye is dynamic, and I often put it like, I had patients like rub their eye, and anything can touch the corneal endothelium if you push on your eye, which is actually fairly easy to indent it. So that's always a long-term concern. And I've had patients like tell me they don't want a device in their eye, and sometimes we get into this little back and forth a little bit. But at one level, I understand it, and it makes sense. So, and I agree. I think because, when we use the iTrack, in glaucoma, the problem thing with IOP control is the trabecular meshwork / canal of Schlemm. So when we're addressing that, number one, because it's a closed system, two, I think the eye pressure drifts down, and I think it's a more physiologic change in pressure versus hitting the floor. And I think that does, cause problems for the corneal endothelium, going back to the safety side of things. But mechanistically, it makes a lot of sense. I agree with you. It's kind of the disease system. And I argue for early intervention. And I really think sometimes it's almost rejuvenative, if that's a word. Rejuvenates the canal of Schlemm and enhances the flow. And I think that's good for the corneal endothelium. I think it's good for the trabecular meshwork, all parts of the system. Do you agree?
Yes, I think especially with the MIGS procedures that we have now, we're intervening earlier, right? And I think, I've been in practice long enough now that I follow my patients over, years, and I can see, the effects that aging has on the cornea, just aging in and of itself, aging in a glaucoma patient, that's additional risk to the corneal endothelium. And then many patients, may require more than one procedure over their lifetimes. That's likely for, our glaucoma patients. So we're intervening earlier in a healthier state, which is great, with safer procedures. But at the same time, we have to be careful with our selection, because these patients have a lifetime now of potential other issues that may occur, or other interventions that may be performed that have incremental effects on the cornea. So I think that first procedure selection should really be the one with the, of course, efficacious, and also the one with the highest safety margin. And so I think, iTrack Canaloplasty, for me, the study results that you and Dr. Lubeck nicely presented, I think, are very in line with what we see in the clinic. Patients that have combined cataract surgery and iTrack Canaloplasty, you cannot differentiate those patients postoperatively from patients that had cataract surgery alone. It's a very gentle procedure, and are treated postoperatively virtually identically to patients who have had cataract surgery alone, with the exception being that we can now ease up on the patient's glaucoma medication burden.
No, I think that's, just follow up on a couple points you made. Number one, that none of these procedures are forever. And I tell my patients everything in glaucoma is temporary, and I hope temporary means like 20 years, but yeah. I think that speaks to this procedure though, because this particular study that we did was in combination with cataract surgery, which I think is these days kind of the first incisional glaucoma intervention. But this is a repeatable procedure. And I always like this because it doesn't change any future options. I always like to keep as many options for future interventions as open as possible. And we don't destroy any tissue. I've gone back in a number of these patients, actually in some of these study patients, for a second procedure, and we can get a repeat kind of effect. So I think that speaks to, like you said, the gentleness of it, but also kind of getting to the mechanism of why they need it.
Yeah, I absolutely agree. That's something that I teach our residents and fellows. Think 2-3 steps ahead. It's kind of like strategy. It's like chess. Think ahead of yourself, and don't take any options off the table when making your decision in present day.
Yeah. And then just like part two, to get back to what you said about inflammation, I agree. Traditional glaucoma surgery, you have it in clinic. You can tell who had the traditional glaucoma surgery and who had like regular cataract surgery. You don't want to mix those populations too tightly. Your premium IOL patients and your, valve patients.
Right.
That's not good. But I think once again, what speaks to this is we tend not to get shallowing. And in the past, we used to be like, the anterior chamber's a little shallow, just wait it out. That's okay. Actually, based on my more recent experience with MIGS, I don't think that's okay. And if you look, a lot of these patients have PAS after a trabeculectomy or an expression, some aggressive IOP lowering. And I think that PAS speaks to the inflammation that's really associated there. And it speaks to the mechanism of failure in some of these patients. where you really don't see the big drop in pressure. The anterior, like you said, the anterior chamber looks great from day one, and then it's just getting them to heal up a little bit. So I think you're right, and inflammation is really problematic both for the corneal endothelium and just treat the glaucoma in the long term.
Yeah. I mean, there's no question anterior chamber shallowing, peripheral anterior synechiae, these are not natural events. And in fact, going back into the literature, looking at studies that have examined factors that increase risk for corneal endothelial cell loss after traditional glaucoma filtering operations, one of those studies found that the only independent factor that led to increased risk to corneal endothelial cell compromise was the presence of peripheral anterior synechiae in a dose-dependent manner. So the greater the degree of peripheral anterior synechiae, the higher that risk. And that's something to think about. I see peripheral anterior synechiae in any of my patients after any procedure. That puts me on alert and makes me think, and that's going to modify, what I do for that patient, and it's going to modify their risk in a negative way, unfortunately, in terms of future corneal decline.
Yeah. No, I agree, and I think you've brought up all the major kind of, I guess, speaking points or the things to think about when we talk about doing iTrack canaloplasty, and both in conjunction with cataract surgery, but also as a standalone procedure. I think, like I said, it gets to the mechanism of action. It avoids excessive inflammation, and that's good. You see it. It's good for the patients. The patients know it. You know it. You can tell that clinically, but it's also nice to see data to substantiate kind of what we know already clinically. Do you have any closing comments?
No. I think that I've been very pleased with my results with iTrack Canaloplasty. As you said, it doesn't take anything off the table. It rejuvenates the eye's physiologic outflow system. It's beautiful when you see that intraoperatively, that nice episcleral blanching. It's very satisfying. You can see the effects that you're having intraoperatively. And I think that in terms of future corneal health, it's probably the lowest risk option that we have in terms of our MIGS interventions.
Right, so thank you. So thanks again. Thanks, Ahmad. This is Rob Noecker. We're going to go now to the Interventional Glaucoma Congress here in Chicago.